Welcome to the Allergy and Asthma Network's 2016 webinar series. As our title, Advances in Allergy and Asthma Notes, we work to bring you monthly webinars filled with information on clinical issues and current treatment trends for the daily management of issues related to allergies and asthma. We strive to present relevant and meaningful information that will serve you well in your practice and in life. My name is Sally Schessler. I'm the network's Director of Education. This month, we're addressing issues surrounding smoking and asthma. Each month, we bring you nationally respected speakers to talk about concerns that are important to you. Please plan to join us for each webinar in our series. For our December webinar, we're presenting Smoking and Asthma with Dr. Michael Blaiss. Dr. Blaiss is a clinical professor of pediatrics at the Medical College of Georgia in Augusta and executive medical director of the American College of Allergy, Asthma, and Immunology. He received his medical degree from the University of Tennessee Center for Health Sciences in Memphis. He was chief resident at University of Tennessee Le Bonheur Children's Medical Center in Memphis and completed a fellowship in allergy and immunology at Ochsner Medical Foundation in New Orleans, Louisiana. He is board certified in both pediatrics and allergy immunology. He is past president of the American College of Allergy, Asthma, and Immunology. He has served as treasurer of the American Board of Allergy and Clinical Immunology, a past member of the board of directors of the World Allergy Organization, and past president of the Tennessee and Louisiana Societies of Allergy, Asthma, and Immunology. At both Merck and Pfizer Consumer Healthcare, he served in medical affairs roles. In 2005, Dr. Blaiss received the Lifetime Achievement Award from the Louisiana State Allergy, Asthma, and Immunology Society. In 2013, he received the Gold-Headed Cane Award from the American College of Allergy, Asthma, and Immunology. Dr. Blaiss has presented at more than 200 medical meetings and co-authored or edited more than 150 articles and book chapters on subjects in allergy and immunology. We're so pleased to have you with us today, Dr. Blaiss, and we're looking forward to what you have to share with us.
Well, thank you, Sally, and good afternoon, everyone, and let me wish everyone a happy holiday season. What I want to do for you today is cover the subject of smoking and asthma. And as we all know, smoking is a major public health problem that leads to significant respiratory conditions. So we'll be looking specifically at smoking, its relationship to asthma as far as the incidence and the worsening of that particular condition. We'll look at some data as far as things that we can do to help that smoking asthmatic get to that goal of quitting of smoking. And lastly, and very importantly, we're going to talk about e-cigarettes and how that's changing the landscape and how that is affecting the youth of the United States and may lead, in fact, to worsening of asthma in that particular population. So let's first look at some facts related to smoking. And I think what's so disturbing is that tobacco still remains the leading cause of preventable diseases, disability, and death in the United States. And when we talk about public health issues, we talk about cost issues related to health care in the United States, tobacco is still a big share of that. In fact, it kills more people in the United States than alcohol, AIDS, car accidents, illegal drugs, murders, suicides combined, and in fact is responsible for 1 out of every 5 deaths in the United States, and nearly 1/3 of the cancer deaths in this country, obviously the major one, in fact, being lung cancer. Now, we have data from the CDC, and in fact, this was just updated this week because the data from 2015 came out. If you see this data from 2014 on the slide, it's about 16.8% of adults in the United States. So we're talking about individuals 18 years of age and older that are smoking tobacco cigarettes. The latest data that came out this week from the CDC showed some more decline, which I think is terrific. The data now suggests that about 15% of the adult U.S. population is in fact smoking tobacco cigarettes. Obviously, just one person smoking is way too many. So we're still talking about somewhere around 35 million adults in the United States that are smoking cigarettes. It's important to keep pointing out that cigarette smoke is still the leading cause of preventable disease and death in the United States. And in fact, almost 500,000 deaths in the United States can be attributed to cigarette smoking. And over 16 million Americans live with a smoking-related disease, and a substantial number of that 16 million, in fact, it's related to respiratory problems such as COPD and asthma. Now, if we look at smoking rates in the population and looking at groups that have a higher rate of smoking than what we see in the general population, we see some very interesting data, because this gives us information of groups that we really should be targeting when we're working on smoke cessation in the population. So if we look at race, the highest number is in the American Indian, Alaskan Natives. Men have a higher rate of smoking than women in the United States. And the group that has the highest level is the young adult population between 25 and 44 years of age. Very importantly, when we're developing smoke cessation programs, is looking at the education of the patient. And what we're seeing here is that the highest rate of smoking, in fact, is in individuals that do not have a high school degree or have a GED. So we're talking about 66% of people that fall into that educational category, in fact, smoke. And if we look at poverty status, the highest rate is the group that's below poverty level. There are also some other very important groups in the United States that should be targeted, that have a higher rate than what we see in the general population. This includes people with mental health conditions, adults with disabilities, the LGBT community, military service members and veterans, people living with HIV, and you'll notice here asthma. In fact, about 21% of asthmatics smoke. So this is a major group, the group that we work with on a daily basis, that we need to really target smoke cessation. Now, you'll have to indulge me for just a few minutes, but when I give lectures on just about any healthcare topic, I like to look at the history and what we know from the history. So I want to give you just a brief history related to tobacco smoking. And the Mayan Indians, in fact, if we go back several thousand years, in fact, you'll find carvings in stone as far as tobacco use. And we know that when Christopher Columbus and other explorers came to North America, that in fact tobacco was grown by the American Indians, that they used and smoked tobacco primarily related to different types of activities, but it wasn't a chronic use of smoking as we see now in the population. And in fact, Christopher Columbus took back tobacco leaves and tobacco seeds to Europe, in fact, when he returned. Tobacco grew in Europe, grew in the United States, and was a major cash crop in North America. In fact, in 1612, the settlers in Jamestown, in fact, grew tobacco as a cash crop. It continued to prosper in the United States, and the first commercial cigarettes, in fact, were done by Washington Duke, who, in fact, where the name Duke University, or Duke University was named after the American Tobacco Company, and developed the first hand-rolled cigarettes that, in fact, were sold to soldiers at the end of the Civil War. Now, there still wasn't there was a gradual but slow uptake of cigarettes, but what really led to large groups of the population smoking was when James Bossack invented the cigarette making machine in 1881. That made it very easy to have cigarettes made and really led to widespread use of cigarettes throughout the population. And in fact, in both World War I and World War II, soldiers were given cigarettes free, and led to, again, a large group of individuals then addicted to nicotine and to cigarettes. As we got into the 20th century, especially in the 1950s and the early 60s, reports started coming out in the medical literature suggesting that we're starting to see a much higher rate of lung cancer in the population, and there seemed to be a link associated with cigarette smoking. As more of that data came out, the landmark paper in 1964 by the Surgeon General of the United States wrote about the dangers of cigarette smoking and stated that nicotine and tar in cigarettes cause lung cancer. In fact, we now know, and we'll come back to this, that nicotine is not a carcinogen, but nevertheless, tobacco smoke does have, as we'll talk about, carcinogens. And as further data and studies were published after this report, the data confirmed again of the dangers associated with cigarette smoking. In 1965, we had Congress pass the labeling associated with cigarettes, that cigarettes may in fact be hazardous to your health. If we go back through the time when cigarettes were being advertised a great deal throughout the United States, here's some of the articles, and doctors were one of the major groups that were used as far as in advertising. And you can see this particular one, every doctor in private practice was asked, and you can see the list here, what cigarette do you smoke? And you can see here, more doctors smoke Camels. Here's another one with another brand, Lucky Strikes. Again, physicians saying that they're quote unquote less irritating. And also future presidents were also advertising cigarettes here and giving them out for Christmas presents. Just to let you know, I will not be giving anyone cigarettes for the holidays. So if we look at the data, this is the CDC data from 2005 to 2014. And what you see here is the definite trend for a decrease in smoking in the U.S. This is the overall. Here's men up here, women down here. And again, when this came out, it was about 17% of the population. We now know from the data this week that it's about 15% of the U.S. population as far as adults that are continually smoking. Now, this is the Surgeon General report from 2014. So this report came out 50 years after the Surgeon General landmark report that I showed you, linking cigarettes to lung cancer. And what we now know is that cigarettes do much more than lead to just lung cancer. And this is looking at the health consequences linked, in fact, to smoking. And you can see the list of cancers. You can see the list of chronic conditions. And if we look at respiratory, obviously the number one being COPD. In fact, there's a link as far as a higher risk associated with tuberculosis now, asthma, and other respiratory effects. But you can see pretty much throughout the body the damage that tobacco smoke does. And if we look at, from the same report, looking at the health consequences associated with secondhand smoke, if we look at the pediatric population, problems we deal with a great deal in children, middle ear disease, obviously respiratory symptoms, and as I'll show you, obviously increasing the risk for the development of asthma, impaired lung function, and increased risk of lower respiratory illness. And obviously in the adult population here, secondhand smoke associated with lung cancer. And there is some now recent data that suggests secondhand smoke, in fact, can also lead to COPD and possibly also related to asthma. So what does environmental tobacco smoke contain? Whether if we look at the side stream smoke, which is the passive smoke someone would breathe in, or the mainstream smoke, which someone's inhaling from the cigarette, there's over 4,000 compounds. And the disturbing part here is there's over 50 carcinogens that in fact have been isolated from the smoke when one is smoking a cigarette. So here's a list of just some of the chemicals that one is inhaling in the smoke when in fact they are smoking a cigarette. So you can see the different irritants and toxicants, and again, nicotine, which is the addicting substance that is found in cigarettes. It binds to nicotinic receptors in the brain and then leads to, in fact, the release of dopamine. This obviously causes the addiction that we see associated with this product. But you can also see the list of carcinogens here, and this is just a small list of the ones that, in fact, one sees in tobacco smoke. So obviously the risk of cancer is associated with smoking. Now, I want to show you this, and I'll just explain this. This may be a little hard to read depending on the side of your monitor. This is a study by Eric Bateman et al., pulmonologist out of South Africa, that was published last year in Lancet Respiratory Medicine. And they were looking at the overlap syndrome between asthma and COPD. And they're looking at ontogeny, and they're looking at the environment. And what I want to point out here is whether we take the fetus and their maternal risk as far as developing respiratory problems, all the way till we get to old age, smoking has an effect here as far as leading to these respiratory problems. If we look at the fetus, the maternal risk of smoking, when we get to the neonatal child, exposure to environmental tobacco smoke, and then the adolescent, adult, and old age, again, exposure to environmental smoking and environmental smoke exposure, all of these can lead to the worsening and the disease patterns that we see in COPD and asthma. So what do we know? What's the general data as far as the relationship of smoking and asthma? And so I'm going to kind of give you some broad points here, and then we'll look specifically at some of the studies. But what we do know is that cigarette smoke has a major effect clinically on asthma, that smokers with asthma have significantly higher rates of symptoms, severity, poorer quality of life, poorer self-management, and tend to have more exacerbations and hospitalizations. If one looks at the physiology of asthma, they tend to have more acute bronchospasm. And what we do know, and I'll show you the classic study out of Australia in just a minute, is that they have a much more rapid decline in their FEV1 as they age compared to asthmatics that do not smoke. Very importantly is understanding the therapeutics associated with asthma. And one of the major drugs that we use in the treatment of asthma, inhaled corticosteroids. In fact, smoking asthmatics have less response to these medications than non-smoking asthmatics. Also, smoking leads to a more rapid clearance of theophylline. If one looks at the pathology associated with asthma in the smoking asthmatic, one sees further types of inflammatory changes, and I'll show you in a second, primarily related to stimulation of activated macrophages and neutrophils, which one does not classically see in the normal asthmatic patient. So let's look at some of the data here. And first, let's look at some of the data that shows the increased prevalence of asthma if, in fact, one smokes. And a lot of this data seems to suggest that it has done more of an effect on females than in males. So, in fact, what we know is that there's a higher prevalence of asthma developing in female smokers compared to female non-smokers. And this seems to be much higher in the heavy female smokers, in other words, smoking many cigarettes, compared to light smokers or non-smokers. And one of the classic studies was the Canadian National Population Health Survey. And in fact, their data showed that female smokers had a 70% higher prevalence rate of asthma compared to non-smokers. And the interaction between smoking and sex was very high among females less than 25 years of age. In other words, the odds ratio was greater than 2. And again, it was much higher if they were heavy users of tobacco compared to light smokers and non-smokers. What about in the pediatric population? Again, one of the best reviews is out of Burke that was published in Pediatrics back in 2012. So they did a systematic review and meta-analysis of 76 studies that compared exposure both prenatally and postnatally to passive smoke, and they showed that increased the risk in the child anywhere from 25 to 80% as far as development of asthma. And the strongest effect was if, in fact, that infant was exposed during pregnancy, the prenatal maternal smoking, where in that child less than 2 years of age, at that time had an odds ratio of 1.85. So in other words, the mom smoking during pregnancy increased the risk of that child less than 2 years of age of developing asthma by almost 2 times. Also, and I think very interesting, was this article out of 2005, where they looked at adolescents and adults and showed that exposure that when they had exposure to passive smoke, that increased their development of asthma. So what they were able to show in this study is that childhood exposure to passive smoke was associated with an increased risk of developing asthma as an adult with an odds ratio of almost 2. So there is no safe time as far as being exposed to passive smoke. Now, what do we know as far as the clinical outcomes in smokers with asthma? Well, in general, if we compare this in numerous studies to non-smoking asthmatics, those smoking asthmatics have more severe symptoms, as I mentioned, worse quality of life. They use more healthcare resources, especially related to unscheduled doctor visits and frequent hospital admissions. Also, other insurance data has showed a higher use of medication in the smoking asthmatic versus the non-smoking asthmatic. We know that cigarette smoking asthma increases the frequency of exacerbations, of the number of life-threatening asthma attacks, and very disturbingly, asthma mortality is greater among heavy smokers with asthma compared to asthmatics that don't smoke. And if we look at smoking during pregnancy, women that smoke during pregnancy and have asthma have more exacerbations, and their children have more fetal growth abnormality. So again, we can see here how important it is to work as hard as we can to get smoke cessations done in all groups of asthmatics that are smoking. I'm going to show you this study by Michael Schatz. So Michael Schatz is an allergist at Kaiser Permanente in San Diego. And what they looked at here in this article that was from the Journal of Allergy and Clinical Immunology is they looked at the determinants of future long-term asthma control. And they wanted to look at certain predictors. One of the predictors they looked at was current smoking. And what they looked at here was the need for canisters of short-acting beta agonists, albuterol. So one here, they only needed 0 to 2 canisters a day, up to 4, where they were using greater than 12 canisters a year. And you can see the current smoking numbers increasing. In other words, there is an inverse relationship between asthma control and current smoking. The more that the patient smoked, the higher smoking, the more use of albuterol, the poorer the asthma control. What about passive smoking? What do we know, especially in the pediatric population? Well, we know that passive smoking increases in that child with asthma, their symptom scores, their exacerbations, their need for reliever medication. They have a higher number of hospitalization rates, and they have more life-threatening attacks. This is the classic study that was done in Australia. That's the Busselton health study, Busselton's in Western Australia. Now, all of us, when we reach about the age of 20, we reach our peak as far as our lung function, our FEV1, our forced expiratory volume in one second. And what happens over time is we lose a few milliliters of our FEV1 each year. So what we're looking at here is all the way, we're looking at non-asthmatic non-smokers, so the normal population, and this is their lung function here, going down as they get older. And then I want to show you the two asthmatic groups, smokers and non-smokers. So if we look here, this little dotted line here is the non-smoking asthmatic, and this dashed line, which has the worst FEV1, is the smoking asthmatic. And you can see here the big difference here in FEV1. So the whole point of this article, and very important, and one of the things I used to stress to my smoking patients all the time, is that if you smoke and have asthma, you have a much more rapid decline in your lung function as you get older compared to if you have asthma and do not smoke. The other disturbing thing, or one of the other disturbing things associated with smoking, is response to medication. And especially asthmatic smokers do not respond well to one of the major drugs used in the treatment of asthma, and that is inhaled corticosteroids. They also have less response to oral corticosteroids. So when you look at such things as improvement in respiratory symptoms and in lung function and exacerbation rates, the patients that smoke and have asthma do not respond as well as the ones that do not smoke. So let me show you the classic study here. And in fact, this has been now shown in probably literally tens to 100 studies. This is the Pedersen study back in 1996. And they're looking at medium doses of inhaled budesonide and inhaled corticosteroid. So we're taking a group of non-smokers and a group of smokers. So you can see beforehand, the non-smoker FEV1 was about 75%. And with use of inhaled corticosteroids, you can see the significant improvement in their lung function. But look at the smoker group here. Again, there is no change, in fact, in their lung function over the 3-month period with the use of the inhaled corticosteroid. I'm going to show you this study showing the same type of effect occurs with passive smoking. So this was a study in Archives in Pediatric and Adolescent Medicine that was done in Rochester, New York. And what they wanted to look at is they looked at 2 different groups of children. They looked at children that had a school-based care group, and they received their inhaled corticosteroids at school every day, so they knew they were getting their medicine. The other group of children was the usual care group, who were supposed to get their medications at home. Then they compared these groups as to whether they had passive smoking exposure at home or no smoking exposure. So let's look first at the no smoking exposure group. And what you see here is the group that got school-based care, and we know they got their inhaled steroids, showed significantly less total absences, less acute care visits, less hospitalizations, and all of that was statistically significant. But if you look at the 2 groups that, if they have smoke exposure, what you'll notice here is there's no significant difference. So in other words, you do not see the response with inhaled corticosteroids because, in fact, they were exposed to passive smoke. So what happens as far as the inflammation? What happens in the smoking asthmatic? So we're all very familiar with the inflammatory pathways that occur in the typical asthmatic patient, where one has primarily a Th2 lymphocytic response with stimulation of B cells, which can release inflammatory agents, which in fact can have inflammatory effects on the airway epithelium. We have the release of many mediators from mast cells in the allergic asthmatic. But if we add the cigarette smoke here, we get the smoke, in fact, the irritants activating macrophages, which again lead to many different mediators being released, especially tissue proteases, MMPs, which have an inflammatory effect on the epithelial lining. We also get activation of neutrophils, and we also get neutrophil elastase, proteases, all of these leading to inflammatory changes in the airway. So we get a much more altered and really worsening inflammatory component when that asthmatic also smokes. Now, the good news here is if we can get that asthmatic smoker to stop smoking, we can improve their asthma outcomes. And I could literally show you hundreds of studies that document that. Obviously, we don't have that much time today. I've listed 3 studies here, but let me just point out one of the classic ones, and that is the Tonneson study here that was in nicotine tobacco research back in 2005. They looked at 220 asthmatics who had that went through a smoke cessation program with the nicotine replacement therapy. So in most cases, this was the nicotine patch. At 4 months, 27 had stopped smoking, 33 had reduced their smoking, 50 had relapsed or just had continued smoking. If we look at the ones that completely stopped smoking, they had improvements in their asthma quality of life, reductions in day and nighttime need for rescue medication, decreased need in inhaled steroids, improvement in daytime symptoms, and improvement in airway hyperreactivity. And in fact, smaller changes of improvement were also seen in that asthmatic that reduced the number of cigarettes that in fact they were smoking. So the bottom line here is that we need to do everything possible to work with that smoker to ideally to get them to quit smoking, because we can make a major improvement in their asthma condition. So I show you this study that was published this year by Perret in the Journal of Asthma and Allergy. And this is looking at specifically things that can be done to help the smoking asthmatic. And they list 5 different considerations here. So one is the importance in getting the patient to understand the importance of quitting smoking. So reminding the asthmatic smoker at each opportunity, and especially trying to work with the adolescent and young adult smoker, where smoke cessation would get the greatest benefit because less damage, in fact, has been done. Very importantly, giving them important information. One related is I went over the Australian study about the lung function deficit associated with smoking and asthma, that you don't respond as well to asthma medications like corticosteroids. And that the other thing we have to understand is that it's not uncommon for smokers that have tried to quit to relapse. And we have to understand that they have to keep trying. It may take 5 times, it may take 10 times, it doesn't matter. We have to keep working with them to hope eventually get them to completely quit the habit. And giving them important information, work with them in behavioral consultation type of modes. There's a lot of information out there, and I'm going to show you a web-based one that is very important that can help you with your patients that are smoking. Very importantly is optimizing management, especially if they are trying to quit, so that they don't have any type of asthma exacerbation. And if they do get admitted to the hospital, this is an important time as far as a teaching moment, that it's very important that in the hospital, that maybe that's the time one wants to start nicotine replacement therapy or one of the other prescription medications, also start different types of behavioral consulting with the patient to help them, again, kick the habit. And very importantly is the role of follow-up, because these patients do tend to relapse. This is an addiction, and we have to keep working with them and keep educating them to keep them free from the use of tobacco cigarettes. There are important medications out there that can definitely act as aids for smoking cessation. In most cases, they're not going to work alone. There has to be programs along with these agents, but by adding these agents with programs, most studies show you get a higher quit rate than with just programs alone. So we have the nicotine replacement therapies like the patch and the gum. We also have prescription medications such as bupropion. The one that has been shown to be the most efficacious in clinical studies is varenicline. The biggest concern has been associated with psychiatric effects. So a recent study that was published in Lancet has suggested that the risk of psychiatric effects with varenicline, in fact, were no higher than with placebo or nicotine patch, and the FDA is looking at this point in time as far as changing the warning. The bottom line is these therapies are out there and should be used, because there's no doubt that the safety of these agents is much safer than the risk associated and the damage that can be done by tobacco smoke. Very importantly, again, as we mentioned, is education. And if you're not familiar with this, the CDC's National Tobacco Education Campaign, Tips from Former Smokers, hopefully now you will be. In fact, it's important to note that the group sponsoring this lecture today, the Allergy and Asthma Network, in fact, is a professional partner with the CDC in this national tobacco education campaign. So these tips from former smokers have been very instrumental in working throughout the United States, getting smokers to quit smoking. So this campaign brings public awareness about the health damage associated with smoking and exposure to secondhand smoke. It encourages smokers to quit. There's a lot of help out there. There's an 800 number that they can call. There's information on the web at cdc.gov/tips. And there's a lot of, what's interesting here, if you go to the website, it's ex-smokers talking about ways of quitting smoking. So it really is very powerful. Here are some of the key messages: that smoking causes immediate damage to the body, which can lead to long-term health problems. For every person who dies because of smoking, at least 30 people live with a serious smoke-related illness. And now's the time to quit smoking. And if you want help, free assistance is available. Does it work? Yes. In fact, this was an article that was in Lancet entitled "Effect of the First Federally Funded U.S. Anti-Smoking National Media Campaign." It reached in its first year 1.64 million smokers with a quit attempt. And of those, about 100,000 were expected to stay quit as far as their smoking. And more than 6 million non-smokers talked with families and friends and families about the dangers of smoking. So this has been a very successful campaign, and it continues. So here's information about it. Again, you can go to their website, TIPS website at cdc.gov/tips. You can follow them on social media at CDC Tobacco Free. And again, the 1-800 number, quit now. Now, in the remainder of the time I have, I want to move on and talk about something that is unbelievably timely, and that is e-cigarettes and asthma. And I'm showing you this slide, but I'm going to digress here for just a second, because today the Surgeon General came out with a report about e-cigarettes and high school students. And this is from a press release, so I'm just going to read this very quickly. E-cigarettes have become the most commonly used tobacco products among teens and young adults in the U.S., the Surgeon General said today, as he called for prevention efforts to protect our nation's young people from being harmed by these products. The safety of e-cigarettes, which contains nicotine and may contain other chemicals, has been a topic of heated debate, with manufacturers insisting they're safe and public health groups insisting they are dangerous and often a gateway to tobacco use by youth. And I'm going to show you some of that data in just a second. Regardless of safety issues, there is no doubt that e-cigarettes are growing in popularity. E-cigarette use has grown 900% among high school students between 2011 and 2015, the Surgeon General said today. So this is a study that was also published this year from the CDC, looking at high school students reporting use of tobacco products at least one day during the past 30 days. So you can see about 25% using any tobacco product, and you can see the highest rate is electronic cigarettes, much higher than what one sees with quote-unquote tobacco cigarettes, cigars, etc. In the 2014 FDA survey, they showed that high school students' use of e-cigarettes had gone from 1.5% in 2011 to 13.4% in 2014. And that the use of a water pipe, hookah, increased in the high school population from 4.1% to 7.2%. And what I want to show you, and I'll show you one of the studies in just a second, recent research has found that teens who used e-cigarettes were greater than 3 times as likely as others to go on to smoke traditional tobacco cigarettes a year later. So I do think there is data that, in fact, e-cigarettes are a gateway to tobacco use by youth. So what do we mean by e-cigarettes? And there comes in lots of different varieties, but all of these are what we call ENDS, or electronic nicotine delivery systems. And what they are devices that allow the users to inhale an aerosol that contains nicotine and other substances. And if you look at the high school and young adult population, most of these are flavored with many different types of flavoring. So they're also inhaling not only the nicotine, but these flavorants. And compared to traditional tobacco cigarettes, these are battery operated. They have a heating element. It heats the liquid to form the vapor that in fact the individual then inhales. So what are the components? And if you look at the components here, this is completely different than what one sees with a tobacco cigarette. You have inner and outer glass fibers, depending upon how this particular battery heating device is made. So there are particular elements such as silicon and calcium that could get into the respiratory tract and cause inflammation. You have copper wiring in many of these and using a nickel chromium heating element. So you can have parts of those elements getting into the lungs, and they in fact have been associated with respiratory distress. Obviously, we have the nicotine, and nicotine has been shown in fact to aggravate and trigger asthma as an irritant. And there can also be other nanoparticles. And this is not counting the flavoring that is usually used in these particular devices. So the first study I want to show you comes out of South Korea. And what we're looking at here is students in South Korea in high school that have asthma. And what we're looking at here is greater than 4 days absence in the past year related to asthma. Group A, Model A, is unadjusted. Model B is adjusted for gender and family size and where they live. And Model C is adjusted for smoke in the home environment and allergies and atopic dermatitis. So if we look at the top group here, never CC, and C stands here is conventional cigarettes or tobacco cigarettes. And then we look at the use of E-cig, which is electronic or e-cigarettes. So if you look at the group never, then their ratio is 1. If you look at if these high school students are currently using e-cigarettes, their risk of absence related to asthma more than 4 days in the past year in Model A was over 18 times higher, Model B over 13 times higher, Model C over 15 times higher. In other words, there is a much higher risk of missing school related to asthma if in fact that asthmatic high schooler was using an e-cigarette. Now, do we see the same type of thing in the U.S. population? So I'm going to show you this study that was just published a couple of months ago in the American Journal of Preventive Medicine. And this particular study looked at e-cigarette use among Florida youth with and without asthma. So the purpose here was to really get a better idea of the use of e-cigarettes in youth, and very importantly, the use of e-cigarettes in youth that have asthma. So this was high school students in Florida, 2012, almost 500,000. They had demographics, whether they had asthma, had they ever in the past 30 days used e-cigarettes, and then they asked them questions which has been shown in a validated instrument of the likelihood of someone going on to smoke tobacco cigarettes. And then they looked at having asthma attacks in the past 12 months. So the first disturbing results here, we're looking at the prevalence rates of using e-cigarettes, whether you had asthma or not. And what you can see here, for ever using e-cigarettes or past 30 days using e-cigarettes, it was significantly higher in the asthmatic high school student than in the non-asthmatic high school student. So for some reason out there, and maybe they think it's just safer, high school students with asthma are using e-cigarettes at a higher rate than non-asthmatic students. Now, what's very disturbing is this particular data. So what we're looking at over on the left is the proportion susceptible to cigarette smoking among high school students with asthma and never tried regular tobacco cigarettes. So they gave them this questionnaire to find out their likelihood of smoking tobacco cigarettes. So if we look at the first group, ever used e-cigarettes, never used e-cigarettes. It was about a 4 times higher risk of going on to smoking tobacco cigarettes. And if they used e-cigarettes in the past 30 days, the odds ratio increased to 422. Then, if we look over to the right, the proportion reporting an asthma attack among Florida high school students with asthma. And then they looked if they had used e-cigarettes in the past 30 days. And you'll notice here the odds ratio was 1.87, almost 2 times higher risk of having an asthma exacerbation if, in fact, they had been using e-cigarettes. So I think that we have to really now start not only working on tobacco cigarettes in asthma, but I think we also have to be very concerned, especially with the high school and young adult population using e-cigarettes and its effect on the asthmatic patient. So in conclusion, even though the rate has dropped in the United States, smoking is still a major health problem in the U.S., that both active and passive smoke have a detrimental effect on that asthma patient, that all of us in the healthcare profession need to help smokers. We need to use structural programs. We have treatments out there that can be used to kick the habit. I showed you the CDC program that the Allergy and Asthma Network, in fact, is a professional partner. This can be a valuable tool for education to help that patient quit. And I think we need to develop a very strong initiative now on e-cigarettes, because I think it's clear that this can lead to the use of tobacco cigarettes and can lead to definitely worsening of asthma, especially in the adolescent population. So I'm going to stop there, and hopefully we have some time for some interesting, I'm sure we will have some interesting questions. Thank you.
Thank you so much, Dr. Blaiss. We do have some interesting questions. Our first one is, when a patient with asthma continues to smoke, at what point do you stop trialing inhaler alternatives and leave it to the patient to stop tobacco use to gain symptom control?
Well, I think ethically, if we don't have that patient controlled with inhaled corticosteroids because they're smoking, then I guess we need to try other types of treatment so that hopefully we can get their asthma under optimal control. There is data to show that leukotriene receptor antagonists such as montelukast may in fact work better in smokers that have asthma than non-smokers that have asthma. We also have approval for more severe asthma, the use of anticholinergics such as tiotropium. So I do think we have other options. And I think as we use these other options, what we have to do is continue to work with that patient and try to get them to see why we need to try to work with them to quit smoking. I know that in many times it is difficult. It is a very addictive chemical, nicotine. And so we have to be empathetic to that smoking asthmatic. We've got to do everything we can, though, to try to work with them to quit smoking.
Okay, thank you. This next question is in relation to the demographics that you talked about at the beginning. And this person would like to know, are we specifically targeting smoking cessation to American Indians and Alaska as we use the funding from the Tobacco Fund?
So I don't, that's an excellent question. I don't know if it's being targeted, if there are extra programs being targeted to that group. I hope there are, and I know that in some of the other risk groups there are, but I'm not completely sure as far as that particular population.
Okay, thank you. Okay, on the subject of nicotine patches, does the patient need to start at step 1 or the lowest dosage, or can the MD prescribe at any level?
In general, what's done with the patches is you start with the higher doses, and then you wean them down. So in other words, so that's the ideal way of doing it. Let's see if I can go back to the, if I can go very quickly here, let's see. So what you can see here is that usually you start with 21 milligrams. You can, if they're not smoking as much, 14 milligrams, and then you go down to lower levels. So what you try to do is, you know, have them get the patch, get the higher doses, and then they start decreasing the number of cigarettes. And as they do that, then you start weaning down to lower strengths related to the patch. Now, I will tell you what's done a lot that also can be very helpful is using the patch with the gum. So the patch really gives you kind of a slow release of the nicotine, but if that person then still has a craving, then sometimes getting them at the same time then to use the nicotine gum to try to block that craving. There are studies that show that the combination of the two, in fact, may work better than either alone.
Okay. Our next question is there any difference in types of tobacco used in hookah? Is any flavor more dangerous?
What we don't know right now is there flavors that are more dangerous than others? There's a little bit of data out there in the literature to suggest that some of these flavorings may lead to lung damage in and of itself, but there's just not been any research done to really know the answer to that. Now, the FDA is taking over a great deal of control of the e-cigarette and the licensing and availability over time, but that's something that has to be looked at. But one of the things that really scares me about e-cigarettes that we don't know is all these flavorings that the teenagers are using. Are they in fact causing just as much, if not more, damage to that student? So that's a great question. We just don't know the answer at this time.
Okay, here's another timely question. With the legalization of marijuana in Massachusetts, I'm hoping you can talk about the impact of marijuana on the lungs, as we know kids are also putting this in the e-cigarettes. Most of the research I've seen related to the marijuana impact is on the brain. I'm interested in the impact on the lungs.
Okay. So, unfortunately, there's not a lot of data because I've looked this up, and so we don't know of any long-term damage at this particular time because there's just not any data. We do know that marijuana has an effect on theophylline, and it increases theophylline clearance. You will find, I think there's one article in the British Journal that suggests that marijuana may even act as a bronchodilator, but this is one small study. The point being is there's virtually no data out there that we can, say, without a doubt that marijuana is dangerous to the lungs. I'm gonna go out on a limb here and say the answer is it probably is, in the sense that just about any that there's no doubt other chemicals associated in the leaves, and any of the particular smoke that gets into the lungs could have some type of irritant effect. So I think, any type of smoke getting into the lungs, especially of a person with asthma, there's no doubt has the ability to worsen their condition.
Okay, we have time for one last question. And this one is, do you have a favorite patient handout, especially for secondhand smoke and asthma? Anything for low literate populations?
I do use it. I think if you go to that CDC site, there's some excellent materials that can be used for the lower health literacy patient. And so I think that the American Lung Association also has some very good handouts. You can go to their website. those are probably the two best that are off the top of my head right now. I would check, and one of the things we've done is check in your particular city where you live if there are programs. Many universities or medical schools have smoke cessation programs, behavioral type of counseling that people can go to help them kick the habit. So there's a lot of resources out there, and you need to check with your community. You can also check with your health department. And many patients and many of the health departments can get free nicotine patches. So there's a lot out there that can be done to help these patients.
Well, Dr. Blaiss, I think we could probably sit here and talk about this for another hour. But right now, I would just like to thank you so much for being here with us today and sharing all this information with us. We really appreciate it. So to our audience, please be sure to register and join us for the future webinars in our series. Watch for program and registration information for our January webinar on our website. It's www.allergyasthmanetwork.org. Click on Education and then Webinars to register, and also find our recorded webinars. Our webinar series helps the Allergy and Asthma Network to live out our mission to end needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. And as we complete our final webinar for 2016, I would encourage you to access the Allergy and Asthma Network's website for valuable information with sections designed for patients and healthcare professionals. And this webinar, along with our archives from all our past webinars, are posted in the education section of our website. Look for webinars and click on that link. Thank you for joining us today. On behalf of the staff of the Allergy and Asthma Network, this is Sally Schessler, Director of Education. We look forward to having you join us for our 2017 webinars.